Hello, everyone. Welcome and thank you for joining us. My name is Linda Herman. I am the Client Relations Manager for Imaging Biometrics. And today we are excited to be presenting the first in a series of webinars focused on the use and clinical application of IB software. Today's presentation will be presented by Professor Kathleen Schmainda from the Medical College of Wisconsin. The title of her talk is Delta T1 Maps Defined with Examples of Clinical Utility. We have quite a few people on the call today, so you will see that your microphones have been muted, but we encourage you to please use the chat feature to ask any questions. We will also be recording today's presentation for future use. And now I will go ahead and turn this over to Dr. Schmainda.
I will share my presentation. All right, are we good to go? Is it visible?
Yes, it is.
Wonderful, thank you. So thanks to Imaging Biometrics for inviting me to speak about their use of their Delta T1 tool. So in this brief presentation, I'm just going to talk a little bit about what this is, how it was developed, and then how we're using it clinically in studies and on a daily basis. This is my required financial conflict of interest slide. And so the focus of my discussion of Delta T1s is first going to be simply what are Delta T1 maps. Second, as I mentioned, what studies have already been published using Delta T1? How is it being used daily for clinical use? And then finally, some practical tips about generating and troubleshooting these maps when they're not everything maybe that we're hoping for. So first, Delta T1 defined. So delta, of course, is just the Greek symbol delta that means difference. So this is how we refer to them, Delta T1 maps. And they're simply, as input, they take the pre-contrast T1 weighted image and the post-contrast T1 weighted image. And these maps are each individually calibrated or standardized to create this beautiful difference map called Delta T1. So a more stepwise description of how these maps are determined are shown with this graphic. So this is pretty much behind the scenes steps that are utilized to create the maps. So first, as I mentioned, we have the pre-contrast T1 and the post-contrast T1 maps, and these are simply registered together. Second, this proprietary standardization algorithm is applied individually to both the pre and the post-contrast T1 weighted image. It's a transformation step that transposes the images so they're on a fixed scale. It's kind of a histogram matching step that was previously determined. And so as output now we have registered and standardized pre and post T1 images, and simply subtracted one from the other to get our Delta T1 maps. So it's the standardization step that really is a unique part of this transformation. So just a few extra words about this step. Development of what was called standardization was published by Newell et al. In 2000 out of the University of Pennsylvania. And as they clearly stated in their paper, this transformation addresses a major drawback of MRI. So MRI gives us beautiful soft tissue contrast, but as we know, it's qualitative values. It's not quantifiable. So there's a lack of standard and quantifiable interpretation of image intensities. It's very different than, X-ray images where they have Hounsfield units. We don't, we just see differences. So with standardization, it transforms images so that for the same protocol and same body region, similar intensities will have similar tissue meaning. So Imaging Biometrics further developed and implemented this unique algorithm. So the first part of that implementation was to perform that training step to learn the standard histogram for T1 and post-contrast T1 images. So this is the proprietary standardization file that's incorporated into the workflow. And now just to note, this is performed once for all time. Users who generate Delta T1 maps do not have to worry about this. It's internal to the processing, and it already exists for our T1 images. The beauty of this standardization step, this transformation, is that it works for all MRI scanner vendors and field strengths. It's not like it has to be determined for each site or each field strength or each vendor. It works for all MRI scanners and field strengths. And so IB's unique offering is through IB Delta Suite or IB Clinic, and where you take these standardized maps and create the difference map from, again, the standardized pre and post T1 weighted images, and that gives us our Delta T1 maps. So that's kind of what's under the hood for the creation of Delta T1 maps. There's several advantages to these maps. First off, they are not confounded by bright pre-contrast T1 signal, which can be very problematic, especially when you're looking at patients, monitoring them and looking at their response to treatment. As shown in this example here from a patient from the Akron 6677 trial. This is a patient with recurrent glioblastoma treated with bevacizumab. And you can see very clearly there's a lot of bright pre-contrast signal on the T1 image. And then after you administer the contrast agent, you have more bright signal. But how do you distinguish that more signal from what was already existing? And that's where Delta T1 maps make it easy. It turns out this was very important for the 6677 trial, and the success of that trial, as I will briefly describe a little bit later. The other advantage of the Delta T1 maps is that they are quantitative, and this is really important when we want to determine region of interest. So basically, because it's on this calibrated scale, we can sort of semi-automatically determine the region of enhancing tumor. It simply requires drawing a rough bounding ROI around that general area. And then once that rough bounding ROI is drawn, you simply apply a fixed threshold to automatically and objectively determine the region of enhancing lesion from which an enhancing volume can be determined. Again, each of these steps are in the workflow that IB provides, so it's quite easy, and the application of the fixed threshold is also incorporated into that workflow. Another advantage we found as we were performing some of these studies is that there's a lot of indication that because we're quantitative, because we're consistent, that it seems that there are some cases where we can actually be more sensitive to progression. And this is another example from the 6677 trial, where you can see at week 8, not so clear that there's any enhancement that becomes readily apparent at week 16. However, if you look at the Delta T1 maps, the indication of progression is 8 weeks sooner, which is substantial for these patients that do not have a very long survival. So advantages again for Delta T1 in summary are they're not confounded by bright pre-contrast T1 signal. Now one may say, well, that's true of difference maps. Not so much so, because they're not exactly quantitative, and the subtraction gets rid of any possible confounds in that regard. They're consistent across time because the same calibration file is used across vendors and field strength. They're quantitative, enabling objective determination of tumor regions of interest, and more sensitive to progression, as we've begun to realize in some cases. So next, what are the studies that kind of back up some of these advantages? Well, the first study I initially alluded to is the Akron 6677 trial. So this is an advanced imaging trial that was married to the RT-OG 0625 trial, and that was a trial where they're looking at the response of patients with recurrent glioblastoma to bevacizumab. And as I showed you previously, this was a very problematic case because not only do you have bright signal pre-contrast, but because of bevacizumab, which we know decreases the permeability of the blood-brain barrier, the enhancement is more subtle. So it's doubly problematic. And again, Delta T1 was able to pull out the enhancing lesion. And as I began to say later, this was critically important for evaluating the advanced imaging metrics. We needed to know where is the enhancing lesion from which then we measure, for example, perfusion. And it was only in this way that we were able to actually directly address or evaluate these advanced imaging markers like RCBV and show that it was predictive of outcomes. With some patients that are clearly have better outcomes with perfusion that was decreasing over time. And this in one particular case, I think really kind of nails home the point. This is one patient where you can see the two readers. So as you're probably all well aware with multi-center clinical trials, you have several expert readers, neuroradiologists, who will delineate enhancing lesion. And for this one case here, you can show that their identification of enhancing lesion varied over time, between months 1, 3, and 5, and compared to each other. So the expert agreement was not perfect. So that's less good for, of course, determining if there's progression or not. But then when you're trying to look at advanced imaging metrics such as RCBV, it could have a tremendously more important impact because not only is the total volume different, but the area that they draw in terms of where the enhancing lesion is makes a difference in the RCBV you measure. So we're not going to get reliable measures of advanced imaging metrics either. So doing the identification of enhancing lesion is just important for many, many different reasons. So because of the success of using delta T1 in this first trial, it sort of saved the trial in a way in terms of being able to have enough studies to analyze to determine the efficacy of RCBV. And because of the success in this trial, it was then used in follow-up trials like the 6686 trial. It was upfront bevacizumab treatment in patients with newly diagnosed glioblastoma with, again, very positive results. And then in the 6684 study, the delta T1 ROIs were used for the DSC analysis. There's also DCE analysis, all in comparison to the 18F MISO-PET. And because of the success, it's used now in the actively enrolling ECOG-ACRIN EAF 151 trial. So this is all great. I mean, delta T1 shows definitely it's very useful in kind of a means to the end of evaluating the advanced imaging metrics. But then we wanted to ask the question, well, can it replace central reader analysis altogether? So again, for the central reader analysis, it depends, and it has been for years, depending upon what's called the RANO criteria. So basically, the radiologist will find the image slice with the largest extensive tumor and draw, the perpendicular, the line, and then you draw another perpendicular line, and you take the product of the two to get an estimate of the area. And this is what's the standard criteria used to determine if there's response or progression. And it's very inefficient. It requires greater than 2 expert readers. It's the inter-reader agreement is really not good, 50 to 60%, so not much better than chance. And then there's poor consensus regarding tumor progression. So you can imagine by having this substandard way of determining extent of enhancing lesion, you could also be missing some important results with regard to therapies that actually could be effective, at least in some patients. So our question was, well, can we just replace central reader analysis with our delta T1 method? So we did a retrospective analysis of the central reader data from this study, and basically to compare that expert assessment of the standard post-contrast T1 to our delta T1 methods. And we found that there was perfect agreement at week 8 in distinguishing progression from non-progression, and so much so that their survival curves are completely overlapping, so it can make that distinction or at the early time point. At a later time point, the agreement was a bit less. However, both techniques were able to predict outcomes similarly in a significant way. So the fact that there's not perfect agreement, it makes sense. One's, the simplistic 2D perpendicular diameters, and one is measuring the entire extent of the enhancing volume. What we further determined in this study is that the delta T1 further stratifies these patients in distinguishing those that responded from those who are non-responders and non-progressors. So it seemed to have an additional biologic effect in determining outcomes. So because we show that it's giving us the same, but in a better way, this information about enhancing lesion, it now has completely replaced central reader analysis for the current trial, the EAF 151 trial. So definitely a lot of evidence to indicate that delta T1 is a better and more efficient way to go for multi-center clinical trials. So what about daily clinical use? So I just have a few examples here to show how we at the medical college are using this on a fairly routine basis. The first is just determining the extent of resection. So it's well known for the most aggressive primary brain tumor, glioblastoma, that how much of that enhancing tumor, how much of the tumor can be removed will be predictive of how long the patient survives. So for those patients that had more tumor removed, which is shown in the blue in the survival curves, they had longer survival than when less than a certain threshold was removed. So delta T1s is actually a perfect solution to make this determination. This is one example of a 13-month-old patient. We can see the pre and post T1 images. Now, in this particular case, of course, the enhancing lesion is obvious. Your delta T1 maps are not needed to, delineate the extent of that enhancing lesion. However, post-surgery is a little bit more challenging. Here we can see in the pre-contrast T1 weighted image, there's definitely some remaining bright signal, probably from blood product. After contrast, maybe a little bit more enhancement, but you really can't tell and distinguish what's residual enhancing lesion compared to the pre-contrast image. However, if we create our delta T1 maps, we can see that there's not much lesion remaining, and it's you can see also the location of the enhancing lesion. And this is a huge advance because at the time this was taken, the neurosurgeon is like, well, we're going to probably have to wait at least a month before we know for sure how good the resection, the extent of resection was. And here now you can plan your follow-up treatment immediately by knowing what's left over. We've also been doing a study in adults, adult patients with wild-type, IDH wild-type glioblastoma. Same kind of story, pre-op versus post-op. Post-op, it's clear that, there's some bright T1 signal pre-contrast, not much different than post-contrast. And in fact, when we take our delta T1 or create our delta T1 maps, we can see that it was pretty much a gross total resection. So this is what we're in the process of reporting or submitting a more extensive study on the use of delta T1 for extent of resection. But this is also quite timely because I don't know how many are aware of the new RANO Resect consortium that has come together. This is an international group of investigators, and they've come together to design this new classification system for reporting the extent of resection in glioblastoma. And in this report, you can see that their recommended categories are very dependent upon determining the volume of contrast enhancement post-surgery. A key conclusion from that study, or their consensus, was that simply measuring residual tumor volume, defined only as the volume of post-surgical contrast enhancement, replaced the need to measure percent reduction. So that was the major conclusion. But a key challenge that the lead investigators even have personally told me about is that the current manual methods for measuring post-surgical contrast enhancement are problematic because everyone's still using their own method or the RANO method I described earlier. So this is another application where on a daily basis or also for studies, delta T1 is a really outstanding potential solution. Other ways it's being used more routinely is just daily treatment monitoring. And this is a good example of that. And I have here the words from our neuro-oncologist. She says, take a look at this person's MRI from yesterday compared to her prior one in May. The T1 with contrast is hard to interpret, but I think the delta T1s says it all. And so you can clearly see that the extent of enhancing lesion, and it helps to plan the next steps for treatment. Here's another example of a patient, and this patient, as you can see on the left here, was already being treated with bevacizumab, which, as we know, decreases the amount of contrast enhancement you'll see, so it's difficult to discern. And this was before they started radiation therapy, and difficult on the post-contrast T1, but more clear on the delta T1s. And then in the second image here, in the second column, we can see that again, it's difficult to discern, the amount of enhancement is radiation being effective, and the delta T1 again helps with that interpretation. So again, a great example of delta T1 and how it was helpful to demonstrate improvement in contrast enhancement. The T1 plus contrast is so ill-defined that delta T1 helps to better assess what is going on. Another example, and this is very, fairly common with treatment monitoring, because you have a lot of that, treatment-induced bright signal in the pre-contrast. It's hard to distinguish from the post-contrast, and delta T1 is clearly helpful in that regard. Here's another example, again, subtle enhancement. Post-contrast, can't really tell how much different it is from pre-contrast, yet these are the images that are typically used for planning of tumor treating fields, for example. And our neuro-oncologist, again, used delta T1s to guide a planning for the tumor treating fields. So practical tips on delta T1. So as I mentioned before and showed you with the graphical workflow, delta T1 is much different or better than simple difference maps. And that's shown in this example here, where at left, of course, is the post-contrast T1 weighted image, and the middle image is just our difference image without doing any standardization or calibration. So you might argue that, yeah, you can see where the enhancement is true. You can see the greater enhancement compared to just the post-contrast. However, delta T1 makes that so much easier and lends so much more confidence in that determination. And also, the quantitative part is really important, because it'd be really hard to draw the outline around the enhancing lesion with a simple difference map. The other thing that sometimes we've come upon is when we see a delta T1 map like the example shown here, and it's kind of ugly, and you see all this spiculated signal that seems to be basically from small vessels. Typically, more often than not, when they don't look good, it's because the images were collected differently. One requirement of delta T1 is that they're matched. So this actually turns out that in this T1 image, the flow compensation was off. Yet in the post-contrast, the flow compensation was on. And this is something that we could validate just by looking at the metadata. And we can see that flow comp was on for one and not for the other. So the standardization step, the transformation step, can handle if there's slight differences in TE and TR, as long as they're both, spin echo 2D images for, matched in that way, but not when you do something as drastic as having flow comp on for one for not the other. So it's just one way to troubleshoot. This is another example. This is a pre-contrast 3D image, pre and post. Which also just speaks to the fact that delta T1s can be created for 2D and 3D as long as the pre and post are matched. But in this particular example, you notice there's just a lot of reddish color on one half of the brain here. And so it looks like the the difference in the calibration is slightly off. Turns out, when you look at the actual acquisition, this pre-contrast 3D had inversion recovery, whereas the post-contrast did not. So it's, very much like having the flow comp on and off. This is inversion recovery on and off. So they have to be matched for a delta T1 to work correctly. And then finally, one thing we find as we're, working towards more quantifiable images, you start to be a little bit more sensitive to imperfections in the actual equipment or the acquisition protocols. And one area that we noticed is sometimes there's this image bias, and it's these low frequency variations across the image that can't necessarily see by looking at the pre and the post T1 images. But when you try to quantify, you notice these differences. And that's what's shown at right. Is there's sort of this dark area in part of the delta T1. Well, this is when, in a case like this, you can apply bias correction, which Imaging Biometrics has incorporated as an option to correct some of these images. So bias correction can be applied to the pre and the post contrast images. And then we see that we have a nice, a clean delta T1 map in comparison. So definitely helpful. So my topics today are talking about, what are delta T1 maps? Hopefully it was more clear now that they are quantitative difference maps, calibrated different maps, and they're vendor and field strength agnostic. They apply across all platforms and field strengths. The overview of studies using delta T1. So several multi-center clinical trials that really benefited from use of delta T1 that show clinical utility of advanced imaging markers, but also show that delta T1 could and maybe should replace central reader analysis. For daily clinical use, we found delta T1s really to be very easy to use and clearly clinically impactful, as I hope a couple of my examples demonstrated. And then finally, practical tips. Your delta T1 is only going to be as good as your input data. So if there's problems, the first thing to look at is what is your input data. If it's not correct, if it's not collected the same way pre and post, or if there's some actual platform issues, you might see some imperfect delta T1 maps. So before I open for questions, I just wanted to give a little promo for the next users group meeting, which is April 11th, and we will have Dr. Michael Ives speaking to us about clinical advances of perfusion MRI in the current neuro-oncology landscape. Gives a great talk about use of some of the IB tools to evaluate brain tumor patients. So open for questions. We were kind of hoping this users group meeting would be more interactive, less like a formal seminar presentation, right? People can just share ideas, what works, doesn't work, ask questions about some of these tools.
We do have a question.
Oh, we do? Okay.
Specifically, how do you incorporate RCBV with delta T1?
How we incorporate delta T1. Well, when we're doing our analysis with perfusion maps and you want to determine a mean RCBV, for example, of enhancing lesion, we always use delta T1s. We also use delta T1s together with the RCBV maps to create class maps called fractional tumor burden maps, which have been shown to be really helpful in distinguishing tumor from treatment effect. So it's kind of a routine part of what we do for our analysis. Makes it easy, makes it more robust. I know we're getting a lot of consistency.
Another question, do you recommend minimal time delay between the acquisition of post-T1 image and contrast injection?
That's an excellent question. So typically, the delay has been about 5 to 6 minutes. So that's sort of the typical delay. And so that's sort of been the recommended delay. But I think there's enough variability that it's something to look at more closely in terms of how much the degree of enhancement might change if you wait 5 minutes versus 10 or 15 minutes, for example. but typically it's about 5 to 6 minutes that people have gotten the best results.
Next, has delta T1 been used for metastases?
Oh yeah, we use it routinely, just as much as I've shown with, that would have been a great example to show. But yep, absolutely. Yeah, it's very helpful. And where it can be really helpful too is in melanoma, where you have a lot more blood product, right? To tease out some of that blood product and see where it's really enhancing.
Another question, is the perfusion series also standardized as the T1 series are?
Yes, so the perfusion has the option of creating what we call standardized relative cerebral blood volume maps. So in a similar way, that calibration file was separately determined for RCBV data. So it's a different calibration file, but the same basic principle applies. The beauty with including or creating standardized maps is you no longer need to draw that reference ROI and normal pairing white matter, as many do, to get consistency over time. So just even visually, it helps tremendously in looking at a patient's RCBV scans over time to see if there's changes, even just for qualitative purposes. So yeah, that's all we use at this point. We no longer do normalized in my own lab, but both are available through the Imaging Biometrics options, the software plugins.
What about the use of this approach in preclinical imaging studies? For example, in experimental autoimmune encephalomyelitis, a model of multiple sclerosis, gadolinium-enhancing lesions are very diffuse and difficult to quantify.
Mm-hmm.
And you can see that question in the chat if it was too much to absorb at once.
Oh, okay. Yeah, no, I mean, delta T1s can apply. We use those. We do some preclinical studies in the lab, and we do create delta T1 maps for those also. So it definitely can help identify enhancing lesions in mice and rat models also. So absolutely, it does make things a lot easier. And again, because it's quantitative, we can apply those thresholds, and then it's easier to sort of quantify volume and number of lesions.
That exhausts all the questions at the moment. If anybody else has any others, please feel free to enter them in either the chat window or the Q&A window. We're monitoring both.
Those are all great questions. We have a lot of expert users.
Yes, there are a few more. Next one, has anyone compared delta T1 with perfusion map or K-trans map in terms of the spatial extent?
I do not think there has been a systematic comparison, but that's a great question. Some years ago, we did somewhat of a comparison, and it was clear that they're not exact, right? So, our analysis now, we create delta T1s and we look at RCBV within the delta T1s, like the mean RCBV, for example. But is that necessarily the best way to go? Because we often will see areas of hyperperfusion outside the enhancing lesion, So the question is, how do you best get at that in terms of reporting that information? So it's a great question. I think they do give you different information, and they oftentimes can be spatially different also.
For the bias correction, at what point would that be applied?
That we don't have to use very often. It's just when sometimes we get these maps where we have this like very dark signal and the delta T1s, and then when we apply the bias correction, it takes care of that sort of low frequency fluctuation in the images. So not very often. I mean, it's not something I think you want to use on a routine basis, but sometimes if there is that image variation, especially in the region of interest, that's when we apply them to make sure we're seeing what we should see. And that's the bias correction incorporated into imaging biometrics. And Tim, you can maybe speak to this better, but it's the standard one that is generally accepted in the imaging world in terms of the bias correction methods.
Any concerns about variability in sequences across vendors?
No, I mean that's where there's the beauty of the standardization, because you're basically taking, some variable input and transforming it to a pre-calibrated scale. So it takes care of those variations, like I mentioned, field strength and vendor differences. The only thing is you just want to make sure you have the pre and post matching. So we've had excellent. Go ahead.
No, please.
No, I said so. Yeah, so that's why it's just really helpful for the clinical trials. I mean, in the multi-center clinical trials, we had all the different types of vendors and field strengths, and so it showed great utility in that situation.
Along similar lines, you mentioned applying a fixed threshold while drawing the bounding box for the ROI. Does this threshold vary across patients?
No. Again, it's because you have quantitative maps. So the whole idea of standardization is, white matter should have the same value each time across patients, across time, across vendors, across field strength, right? So there is a threshold, a previously determined threshold that was determined that you can apply to, so you can see the truly enhancing lesion. So it's the same threshold applied across, patients and vendors and field strengths. These are great questions.
They are.
Really good.
I'm not seeing any others. Whoop. In terms of automatic detection of tumor burden, does Delta T1 maps add value?
Yeah, I mean, it's the required step when we create our fractional tumor burden maps, because we want to look at the perfusion levels within the truly enhancing lesion. So that right now it's kind of the only way to do that. All right.
I think I'm seeing all of the questions answered. I think we've covered everything. I think maybe just another few more seconds. We are coming up on 40 minutes past the hour.
Wonderful. So anybody, I just want to mention, so, as I covered a little bit of the development of Delta T1, I mean, I guess what we're hoping for, I think, if it's okay if I speak for you, Tim, on Imaging Biometrics, is just users of the tools. Even if you present a case and want feedback, just to have sort of a forum in which people can discuss their use of the tools, what works, what doesn't work, ideas, anything at all. So we can all just learn from each other. You don't have to know exactly how the different tools were developed. Maybe just share how they were applied in your particular setting. Be really great. All right. Well, thank you.
Thanks for joining us, everyone. We really appreciate you taking the time. I have a hand going up here. Whoop, it just went down. And so again, thank you very much for taking the time out to join us today. We hope you found the presentation informative. A reminder that Dr. Michael Ives' presentation is coming up on April 11th. We'll be sending out more information as we get closer to that. So again, thank you all very, very much. We will also send out links to the email and Kathleen's slides in a day or so after we get everything edited down and posted. So again, I hope you all have a very wonderful day, and thank you very much for joining us.
Thank you.